Welcome. I hope you find watching this short presentation on some of the learning points that were generated from the Safeguarding Adults Review on Adam useful. My name is David Pride and I was the independent chair and report writer for this process. Adam had a mild learning disability but was described by practitioners who worked with him as a charismatic, sociable and undemanding man. He did not have any drug or alcohol dependencies, but he was clinically obese and did suffer from asthma. Adam lived with his older brother in a flat for a number of years. There was a history of complaints of poor maintenance and rubbish accumulation, which led to vermin infestation. His older brother returned to the family home to care for their frail mother in late 2018. A few months later, Adam abandoned the flat and also returned to the family home, where his brother, mum and younger stepbrother lived. All were codependent on each other for their social care. In June 2019, Adult Social Care received a safeguarding referral from the housing provider. Contractors had been in Adam's flat and reported it was in a very poor condition and not fit for human habitation. Adam was allocated a social worker in July 2019. Adam advised that all he wanted from social services was assistance to complete his personal independent payment application. The social worker arranged for the appropriate support from the Kent Pathways Service and referred him to the Learning Disability team to deal with his asthma. Adam, with one exception, did not keep his appointments with the Pathways Service and decided to make his application independently. The learning disability nurse did contact Adam. He advised the nurse he was under the care of his GP for his asthma and did not need any assistance. The GP records, however, show the GP had not seen Adam for over a year. In October 2019, Adam's social worker was asked to convene an interagency professionals meeting and invoke the self-neglect policy. Neither of these actions took place. There would appear to have been some confusion internally in adult social care as to who was expected to do what, but probably the main reason was Adam had moved out of the flat and had given up his tenancy, and he had concluded his engagement with his social worker. In January 2020, Adam's mother contacted the GP about Adam's severe groin pain. Adam was advised to go to hospital. A follow-up call 9 hours later repeated he should call an ambulance and go to hospital. Adam didn't go. In April 2020, Adam was placed on the weekly welfare call list by Adult Social Care in response to vulnerable people self-isolating because of COVID. At the same time, the social worker for Adam's stepbrother reported that the family home was in a very poor state, that Adam was sleeping on the floor and that his asthma was getting worse. This information sharing was good practice. Unfortunately, this notification was not followed up with Adam. This was because of the impact of COVID restrictions on home visits. The contact number provided was a digit out, and the correspondence inviting him to get in touch was sent to his old address. It was assumed his subsequent lack of contact indicated he did not want help. COVID did bring significant disruption to all health and social care agencies, especially around normal working practices, which were effectively suspended to comply with the national guidelines. In November 2020, the housing provider raised a further safeguarding concern. They reported the family home was in a very poor state and overrun with vermin. The safeguarding concern was taken forward for Adam's two siblings, who were both open to other social care teams at that time. Although Adam was living in the house, no contact was made with him. There was good liaison between the two social worker teams already involved, but Adam was deemed, based on past responses, to have capacity and was therefore not considered to be at risk. In June 2021, paramedics attended the family home to respond to Adam's older brother who had suffered a stroke. They raised a safeguarding concern about his brother and highlighted the potential risk of harm to Adam and his mother. The house was described as incredibly dirty. Adult social care progressed the risks identified for Adam's brother, but did not speak to Adam or his mum. The assumption was a care needs assessment for Adam's older brother would generate the same outcome for other family members. The older brother declined any support, so the process stopped there, and Adam and his mum were never spoken to. The following month, paramedics attended the house again. Adam was found lying in a ground floor room in very unhygienic conditions. He had been there for at least 4 days without any food or water. Adam was taken to hospital where he sadly passed away the next day. He was 37. The SAR report has identified a number of recommendations that are specific to individual organisations. It is probably a good time to remind colleagues that people who decline help or support should not be automatically signed off or discharged until some efforts are made to establish why they have decided not to accept help or follow medical advice. This is the essence of a trauma-centred approach to non-engagement, which is an approach many organisations have now adopted. There are two themes across organisational boundaries that I would like to comment upon. The first theme is there are a significant number of occasions in the SAR report that demonstrate practitioners were operating in isolation. They dealt effectively with the issue presented to them, but did not go beyond that. Professional curiosity, with a few exceptions, was not evident. Many different organisations had contact with all members of the family during the review period. What was a missed opportunity was the link between how the needs of one member of the family would impact upon other family members, and especially Adam. Put another way, the think family approach was not universally applied. There are barriers to professional curiosity. Some rest with the organisation, and some are a consequence of how professionals respond to these pressures. However, it is good practice to exercise your professional intuition and triangulate both soft and hard information. Taking at face value what a person says, especially when history would suggest otherwise, or other relevant factors are not fully considered, is not displaying professional curiosity. The second theme is activating the Kent and Medway Safeguarding Adults Board policy for people who self-neglect or display hoarding behaviour. This policy was rewritten in 2022 and provides detailed guidance on what practitioners can do when they encounter people who self-neglect and or hoard. Any agency or organisation can activate this policy, and they should do this as a matter of course if self-neglect or hoarding is suspected. The strength of the policy is it brings health and social care professionals together so they can share and assess the information each agency has and determine the most appropriate action to be. Some people self-neglect because they are unable to look after their daily needs, and that can be resolved under the Care Act. Others self-neglect because they are unwilling, for whatever reason, to look after themselves. This is where the multi-agency protocol can help. It may not change the outcome, but it is a mechanism that allows professionals to make fully informed decisions and provides a record of defendable decision making if a successful intervention cannot be achieved. Thank you for your time, and thank you for listening.